Vera Calladine. I'm responsible for advocacy at Soul City. We're currently engaged in a primary healthcare re-engineering campaign, which is supporting the Department of Health's primary healthcare re-engineering program. It's a 5-year campaign from Soul City's side, but obviously from the Department of Health. They're planning to work on primary healthcare re-engineering for the next 14 to 15 years, as they put in place the structures that are required for the National Health Insurance program. This morning's discussion is really focused on issues outside of the delivery mechanisms of the Department of Health. They're really focused on the social determinants of health, and just in terms of our own campaign, we've highlighted 6 areas because the social determinants can go into many different areas, but these are the issues that affect the quality of life of people and therefore the quality of health that they experience. So the areas that we're focusing on in our campaign at Soul City is gender, water and sanitation, electricity, transport. Those would be the 6 areas that we are focused on. And you would have other areas as well. You'd look at housing, you would look at education. We also focus on basic education. You look at housing, you look at education, you look at gender-based violence, you look at issues of noise. So many different factors actually affect the quality of life of people and the health of people. And we thought that it is important for us during the course of this primary healthcare re-engineering campaign to also look at what issues are affecting the Department of Health. I think many of you in the room today would have heard about the story of the young baby, a 1-month-old baby in Alex, who had 3 of her fingers bitten off and her nose, a bit of her nose, by a rat in Alex last week. And Alex is, not more than 10 k's from where we are right now. And that is unlikely to have happened in Sandton or Bryanston. And the reason it wouldn't happen in Sandton or Bryanston is the social determinants are all addressed in Sandton and Bryanston. There's good water services, good electricity services, good sanitation services. So you're not going to have rats all over the place. You're not going to have uncollected garbage all over the place. Therefore, children in Sandton are unlikely to have the experience of being bitten by a rat. So that's at a very basic level what we mean when we're talking about social determinants of health. We have a brilliant panel, and we're very happy to have this panel to discuss different areas, different topics within social determinants. And I'll let our chairperson, Kevin Ritchie, from the STAR, introduce our panel. And thank you for being here, both the media as well as all of the NGOs that are here. Thank you.
So, thanks very much, ladies and gentlemen, colleagues. Good morning. Well, she stole all my thunder, but when you think about it from a media point of view, health is a constitutional right, and when it goes well, we never really report on it. And then when it goes badly, catastrophically badly, then we write about it. Then we've got babies with fingers bitten off by rats. We've got children going into hospitals on East Rand with burnt fingers and having their feet amputated. We have typhoid outbreaks, cholera outbreaks. I think the beauty of today's discussion is to look at, as we were hearing now, the intersectoral determinants, the interlinkages, and we've got a fantastic panel today. I'll start with, immediately to my right, Dr. Pregs Govender, who has several honorary doctorates, I must tell you, and they're all in law and philosophy, and she's also the winner of the inaugural Ruth First Fellowship. But what she is a is a social activist, currently the Deputy Chair of the South African Human Rights Commission, with a direct focus on water, sanitation, health, and of course access to information. Some of you will remember that as an MP in the first Parliament, and indeed in the second, she was the only MP to register her opposition to the arms bill budget in 2001, and then resigned thereafter. We're very, very grateful to have you here today. We look forward to what you're going to be sharing with us. Next to her is Dr. Themba Moeti, the CEO of the Health Systems Trust, who's worked in East Africa, running the public-private development partnership between the government as well as working in East Africa. Has worked in Botswana, working with the Merck Company Foundation and the Bill and Melinda Gates public-private partnership with the government there, working on AIDS, HIV and AIDS. He holds degrees in medicine from the Royal Free Hospital School of Medicine and a master's degree in public health. Next to Elroy Paulus, the National Advocacy Manager at Black Sash and a member of the Rural Doctors Association of South Africa. He's based in Cape Town and he's been Black Sash's Community Monitoring and Advocacy Project Manager since 2007. Before that, a medical technologist at Grooteskier in the Department of Chemical Pathology. And then finally, Bongiwe Ndondo, the Senior Manager of Research, Monitoring and Evaluations for Soul City. And she's an evaluation specialist with more than 10 years experience in monitoring and evaluating HIV programs. Ladies and gentlemen, the idea is that we will start the panel discussion. Each panelist will receive 5 minutes to speak on their area of expertise, following which we'll have after which we will give them each another opportunity to almost make rejoinders, and then we will open the floor for questions. So if we could start with Dr. Moeti, please.
Thank you very much, Kevin. Good morning, everyone. Thanks for the opportunity to take part in this important discussion. I'm going to be talking generally on primary health care and the importance of the social determinants. Morning.
Hello.
Okay, morning again. As I said, I'm going to be talking, my name is Themba Moeti, as been introduced. I'll be talking broadly on primary health care and the importance of the social determinants of health. And really coming from the perspective that health is a basic human right, as has already been said, and is necessary really for one to live a productive and fulfilled life in everything that one does. And primary health care has been an important strategy to try and ensure equitable access to basic health services and good quality of life. And the ultimate goal of primary health care, as defined by WHO, really is better life, better health for all, by ensuring fair and equitable access. And there are a number of key elements that they've defined that are necessary for this, but amongst these are, reducing exclusion rather, and social disparities in health, organizing health services around people's needs and their expectations, integrating health into all sectors and making sure that all health sectors play their role, and I'll touch on this briefly, and then also increasing stakeholder participation, because at the end of the day, people need to know what their health needs are, they know what their health needs are, they need to be able to determine and shape those services. But it's been recognized, and there is a lot of data to show, that in many settings, and we've been given an example just this morning, what the powerful impact is of social determinants in health. And maybe it's good to start by asking, what are the social determinants of health? And these really, again, WHO has defined quite simply as those conditions in which people are born, grow, live, work, and age. And these have a powerful influence on one's opportunity to obtain optimal health through the life course, and actually are responsible for most of the health inequities that we see in any country. And these are seen, and this is seen between countries, within countries, and within communities, as has been described this morning, where not very far away from Sandton, the conditions of life and the opportunities are very, very different in Alexandria. So, and basically, all these conditions have a powerful influence on one's opportunity to attain optimum health, as I've said. But what's important is that these opportunities and these determinants are really shaped by the distribution of money, power, resources at global, local levels, and differences in access to education, employment, and as others will touch upon, safe water and sanitation as examples. And I think, a very real life example for us in this part of the world are the HIV statistics that we see in South Africa and within the region, where it's quite clear that the poor who are disadvantaged and come from lower socioeconomic strata, if you disaggregate the data, you'll find that they have higher prevalence levels, higher morbidity, mortality, and issues such as education, income are all protected at a population level. And even resources are important in your ability to cope with and live with the disease. And in Botswana, where I've worked for a long time, the data very, very clearly show that. And of course, gender issues are a major concern. So in essence, long-term health outcomes are often shaped by factors which are outside the health sector and the health sector's influence. And the health sector has the responsibility to make sure that there is good access and to reduce the impact of these inequities. But at the end of the day, you do see it in your infant, your mortality, your under 5 mortality, and generally as the economic status of countries and communities grows and improves, so do you see an improvement in their health indicators, such as life expectancy at birth, under 5 survival, and so forth. And there has been, discussion around primary healthcare re-engineering in the country, and this is what Society is working on and what it does. And basically, this is an effort to try and strengthen the health system and put in place reforms that will try and reduce some of these gaps and differences. And of course, the NHI, or National Health Insurance, is a way of trying to make sure that there is adequate funding, which will then enable and ensure universal access to health coverage. But I think if we look at very real life examples, even when healthcare is free, your life situation, the community you come from, your economic status still determines your access. You need to have money to be able to pay for a taxi cab. You may be living very far from those clinics. Roads may be poor in the areas where you live, and all of these things then affect your ability to access care and will affect your health outcomes. And that is why the issue of intersectoral collaboration to produce health is so important, because all sectors have a contribution to make, whether it's water, sanitation, roads. If electricity is unreliable, then emergency services can't be provided properly in clinics and other places. But I think what's not been done well in the past, and this is recognized in the way that the post-2015 global health agenda is being articulated, is that while it's been recognized that other sectors have an important contribution to make, I think as people in the health sector, we haven't done well in making sure that these other sectors are also held accountable for the areas in which they are required to deliver services. Where health outcomes are poor, the health sector is asked to account. But the water sector might be much more important in actually improving health in those areas. So I think mine was really to give a kind of general view of the importance of social determinants and the importance of primary health care and public health policies in making sure that these issues are addressed, where the health sector champions making sure that social determinants are addressed and does its bit in making sure that it doesn't contribute to inequitable access, but also has to lead the campaign in making sure that other sectors make their contribution, but most importantly, are held accountable for that also. And I think it's only that way that we'll see progress in dealing with some of these inequities. But economics is important. Even if you go back to around 1945, if you look at the TB data for many of the countries in Europe, the prevalence of TB started coming down well before the antibiotic era. And it was really when economic conditions in the industrial era improved that health outcomes for these people improve. And it's exactly the same today. So economics is an important driving force. Thank you.
Right, thank you very much. And our next speaker, Elroy, please.
Thank you, Kevin. Thank you to South City and for the opportunity to speak to you this morning. I was on a red-eye flight this morning from Cape Town. So forgive me if I speak a bit slower than usual. In the short 5 minutes afforded to us, I want to talk to you about three things quickly. One, a quick comment on the recent indicators on the nature of poverty and inequality in South Africa, because that's what I was asked to speak about, the impact of poverty and inequality as a social determinant of health, as social determinants of health. I want to give you a couple of insights of our experiences and findings and what ordinary people said about how poverty impacts on health, especially in our recent work, which we are engaging through the RMCH project, of which South City is a partner. And then the limited gains made by the state in 20 years, the danger of it being eroded by immoral and unlawful debit deductions of social grants through private sector interests that the minister herself called unlawful. So Dr. Moeti covered what the social determinants of health are. They differ from country to country, from state to state. There are a range of definitions, but there is commonalities which include social factors impacting on the health of an individual. In the 2003 World Health Organization report, they spoke about social gradients, that life expectancy is shorter and disease more common further down the social ladder. Now, let me just briefly pause there and say to you, that is particularly prevalent in the South African context, where there is a very, very high Gini coefficient. We are ashamedly, again, probably the world's worst and most unequal country in the world, having surpassed Brazil. Brazil in 2006, and I visited that community, reduced inequality and improved their development indicators through cash transfers. Now, our government has done a lot of work in improving the quality of life, especially people living in extreme poverty, through our social grants system. Now, the Black Sash, as you know, has been well known through the years in helping people with social assistance. But my input this morning is not from the perspective of a welfarist or a nanny state. It's from the developmental role that grants can do, in particular with regards to health. I've prepared a slide and I will share that with you. Right now in primary healthcare engineering, I had the privilege of being seconded for a while to work and report to the DG. I was working with the ward-based primary healthcare outreach teams, assisted by Health Systems Trust. I've been into every single province between April and October of last year. The ward-based primary healthcare outreach teams are part of 3 or 4 legs, district clinical specialist teams, school health teams are working in approximately 10 health districts in South Africa, and we are working very closely with the Department of Health in that regard. Now, one of the things to demonstrate the point about poverty and inequality and what Dr. Moeti referred to, intersectoral collaboration, how we throw more money at a problem but the development outcome is worse, is exactly linked to us not talking to sideways. So I go up to a place called Tolo, and there is a gogo sitting with the grandchild, and in the cupboard there's only milligram. And classic symptoms of kwashiorkor, the school health systems team pick that up. Now, if only the metadata of the health information systems could be shared with a social worker earlier on, that child, in terms of her or his brain development, will enable him to participate equally in an economy. That's just one example of 2 government departments being able to talk to each other and getting our people better and having better value in terms of the inputs made. I always use a picture of during the Durban xenophobic crisis of 2 kids sitting watching the mayor's car, but behind them is a refuse dump. Now, one of the things you may know about the Durban area is that labor broking was the problem. Oxfam, the South African Human Rights Commission, and ourselves went behind the scenes, and some of it was linked to the police brutality of community leaders who wanted to raise the issues. Some of it has been linked to the long-standing problems of communities not being heard by the municipality, and that the Ward 5 area, we brought the mayor there. He never saw the poor state of refuse collection in his area. And remember that 30% of diarrheal deaths in children can be prevented by better environmental health care. And there are pictures showing refuse that was never removed for months. Now, one of the things that I thought I would share, and I'm halfway now, Kevin, if you're pointing fingers at me, is that
two-thirds of your time, unfortunately.
this morning, on my way here in the Cape Times, there was a brilliant article by Bishop Jeff Davis. He talks about inequality driven by greed, the destructive pursuit of wealth, and I quote him. He says, contrary to the reigning economic dogma, wealth trickles up rather than down. It is morally unacceptable that with our wealth, there is so much poverty. We need growth, but the right kind, in education, healthcare, and essentials like food, water, sanitation, and housing. A key is found in the writings of Islam, Judaism, and Christianity, all condemning usury, lending money at exorbitant rates of interest. The consequence of usury is that in order to pay back the interest, we have to drill for more oil, clear more forests, catch more fish, and consume more and more goods to pay the interest. In our RMCH work and in our citizen monitoring, people on the ground speaks about, in this I'm quoting from somebody in Adelaide, with reduced social grants or less money, beneficiaries often can't buy enough food supplies, groceries, can't pay prepaid electricity vouchers, default on funeral insurance policy payments, default on clothing needs, are hospitalized for blood pressure, low sugar levels, nervous tension, walk out on their homes and children, can't achieve a reasonable quality of life and can't escape poverty. Families are disrupted, domestic violence, children don't go to school, beneficiaries sell their personal belongings. And yet, we allow private sector businesses to exploit the poor. And I'm going to name them because there's evidence. You remember Cash Paymaster Services is a company owned 100% by Net1. And the Minister of Social Development, Batabili Dlamini, has called the deductions that they are taking through the use of identity documents and SASSA cards, she called it immoral, she called it unlawful. We were advised by the lawyers not to say illegal, because they will argue from a banking perspective, the fact that it came into FICA. But I want to quote the interest rates. I want to quote the people that I interviewed, blind people, charged 200% rates, charged 280% interest, having their money stripped unlawfully, fraudulent activity taking place. Cash Paymaster Services telling SASSA that they paid back the money, and they didn't. And please watch the space, especially next week, about an announcement by the ministerial task team on which I and my colleagues serve, that the minister will be making next week. Thank you very much.
Thank you. Thank you very much indeed. Bongiwe, would you like to speak now for 5 minutes?
Thank you very much. When we talk about social determinants of health, we're obviously talking about the issues around water. We're talking about issues relating to water, sanitation, food security, gender, education, poverty, violence, like my colleagues have already spoken to. Now, these are all factors that affect people at societal level, at community level, and individual level. And yet many times when we try and find solutions to these issues, our approach is not people-centered enough. So this morning I want to talk about the importance of bringing people into this conversation and bringing people in a meaningful way so that they can assist government and forge ahead with that intersectoral approach, but assist government in identifying the areas that they would like addressed most, because it is, after all, the people that are affected. The NDP talks about a social compact to reducing poverty and inequality in South Africa. Now, the NDP is a very important document for South Africa right now and going into the future. And if you think about a social compact or a social contract, we're talking about people or communities identifying what in articulating what they would like their communities to look and feel like. And on the other side, the contractee is government, pledging to be responsive to the needs of the people. Now that's very important. We've already spoken about how children die in this country because of lack of access to water, clean water and sanitation. How children, babies die because of poor choices that their mothers make or their parents make because of a lack of education. Savera Edia spoke about the poor child, the poor baby, 1-month-old baby who had their fingers bitten, 3 of their fingers bitten and their nose bitten by a rodent in Alex. Now all these things are happening, and yet when we talk about water, we talk about it in isolation to education, in isolation to food security. And it's because of this very fragmented approach to providing services to people that we land ourselves with the kind of issues that we are trying to address today. It's the fragmented approach, and it's the lack of proper coordination in the provision of services, I would argue. We have schools in this country that are built without running water or even without a toilet. And when you ask why, you're told that the budget for building a school lies within the Department of Education. And the budget for building a toilet in the school lies within the Department of Public Works. Now, it doesn't take a rocket scientist to figure out where the problem is. Our communities don't ask for a school and then ask for a clinic and then ask for a hospital. Our communities demand a better life. And our approach in providing that better life needs to be a holistic one. We cannot afford to continue with this very fragmented approach to addressing social issues and that actually impact on the health of our people. Now, what I want to propose today is not so much talk about the social determinants of health, but rather a methodology that we have adopted and that we think we could employ in trying to highlight these social determinants of health, but also in trying to address them. Governments provided a lot of platforms through which citizens can engage. We have clinic committees within the health sector. We have hospital boards where people should, where you and I should actually be, taking our concerns to. We even have the IDP process at local level. And yet, despite all these institutions and all these structures, we have a very disempowered citizen. People don't know about the presence of these clinic committees, and if they do, they don't know how they can get involved. In most cases, they don't even know who their representatives are on them. And I think a lot of them remain inaccessible to the ordinary man. And what do I mean by inaccessible? We have a lot of, I was speaking to a friend a few weeks ago who had been involved in, when we go, what is it called, public comment on a policy, public consultation and a policy. And the way these policy documents are written, even I couldn't understand them because of the legal jargon that is used. And yet, we take these policy documents out into the community and expect ordinary people to engage with them in a meaningful way, which really defeats the purpose of any, meaningful public participation. So, within Soul City, through our community-based monitoring, which is a methodology that we use within the health services, we've been able to shift some of these issues. We went into communities and trained the communities and sensitized them about the issues and also the presence of these structures, for their utilization. And what we've seen is that if you have an empowered citizen, if you have an active citizen, which we often talk about, there's a better chance that these people participate in all these institutions, participate in all these important processes, and engage with these structures in a more meaningful way. And through this process, we can link the community. Is that 1 minute? And through this process, we can link the community to the services, and not just the health services, but also all the other important services like your local municipality, as was the case in Alex, because that's clearly an issue of poor management of refuse, which would lie with environmental health within the municipal office. So linking the services and amplifying the voice of the community so that we can be able to address these social, economic and economic factors that impact on health. So I want to propose CBM as a process then, and an opportunity for us to build a more centered approach to development processes, to link the community to health services, and also to drive a multi-sectoral approach to addressing health and the social determinants of health, and also to strengthen accountability of our officials to providing services. Thank you.
Thank you very much. Please pass the microphone down. Pregs, if you're reading.
Thanks very much. I suppose in 5 minutes, the five key points I'd like to raise. One is in relation to the issue of fragmentation that Bongiwe has spoken about, and the question of the social determinants of health not being looked at simply in terms of food, water, sanitation, education, etc., but looked at in terms of poverty and inequality, because people who are poor lack all of those rights. So we ourselves need to actually address the way in which we fragment the rights in thinking about the rights and in trying to address the rights. So the Poverty and Inequality frames the Human Rights Commission strategy, and the issue of water and sanitation, which is the second one. The way in which we approached the rights to water and sanitation was really in terms of looking at it as indivisible to every other right, interdependent with every other right. And what we saw was that those who lacked water and sanitation were the same people who lacked access to decent schools that had proper toilets, water, etc., laboratories, and other essential school facilities. We're going to be going into focusing as a country on gender-based violence in the next while, and yet we know that the lack of water and sanitation has dire consequences for gender-based violence in our country, and the connections are very clear. And I can spell that out in the question time if there's need for that. The third point I want to look at is the issue of what were our key findings. And one of the key findings was the replication of the apartheid spatial geography. Those who don't have rights, who don't enjoy their rights, remain people who are in apartheid's former homelands, townships and informal settlements across our country. And so we have to address that if we're going to change this. It's not a surprise that the child who gets her fingers or her toes bitten by rats is in Alex, not in Sandton. That was a planned program. That was the way in which apartheid worked. It was based on a very clear plan and strategy. It's not accidental. Poverty is not accidental. Inequality is not accidental. So we have to actually look at, whilst the findings reiterated, I think, what all the panelists have pointed to, the need for intergovernmental cooperation and collaboration, the need for greater participation, the question of who's shaping policy. Are those most affected and often worst affected shaping public policy in all areas? The issue of the way in which the Commission tried to hold its hearings on water and sanitation. We also invited other Chapter 9 institutions like the Public Protector to come and deal with cases of corruption. we invited the Commission for Gender Equality to come and deal with the very real impacts, the gendered impacts of a lack of water and sanitation. But those are quite critical questions in relation to collusions, inefficiencies, corruptions, etc. But I want to move to the question of budgets and the way in which who is it that we value, who is valued by our budget choices. And in relation to that, I suppose I want to refer to, even though we've said as in terms of the health, the National Health Department, that community health care workers are critical. And yet there's been, at a local level, cuts in budgets for community health care workers. And we've seen most recently in the Free State the cut in jobs of community health care workers. So what's framing, when people who are making budgets, what frames who they see, what they value, who's invisible, who's silent, in terms of budget technocrats. Obviously, one of the other issues that came up was the issue of capacity building. And again, if you're saying that the apartheid special geography is what's framing who has rights and who doesn't, the question of where you would actually put your capacity building programs is critical. And what we saw was that the DBSA, for example, conducted a program around capacity building for municipalities, but its focus was really on the large metros and the big municipalities, and not the poor municipalities. And even when those big municipalities are trained, they don't seem to be retrained to value poor communities. So where they spend, what the scale of their tariffs are, who's paying in terms of the tariffs, the sliding tariffs, are important things to actually analyze to see who's actually paying. And I suppose the last thing that I want to end with, and obviously the issue of contracts was a critical question. Are those contracts being scrutinized for human rights impact? I want to end with looking at the question of who shapes policy, because the Universal Declaration for Human Rights says that very clearly that to be able to realize the rights in the Declaration, and in South Africa we've got a great constitution and we've signed on and ratified many human rights treaties. But the Universal Declaration says that in order to be able to realize those rights, you have to have a social and international order that will be able to address those rights, to enable governments to address those rights. But if you take, and I want to take three quick illustrations of the way in which that is undermined. So if we take at the local, in our country, if you say that water is a human right and it's not a commodity in terms of our constitution, then you look at who's using the most water, who pays least for the most water, who's wasting most of South Africa's water, and who's polluting most of our water. And that's not the poor community, as illustrated often by the dripping tap in a poor community, in an informal settlement. All the research shows that those who are, in terms of all of those questions, it's business, it's the private sector. So, and I give a statistic here. The government's own statistic about rural water is that those who use most of the rural water, 95% of rural water is used by under 2%. 95% of rural water is used by under 2%. The question of who's those 2%? So you can't change access to water unless you look at that. If you're looking at municipalities in poor rural communities, they can't deal with the need for that water by just simply looking at the 5%. The other two are the issue of food. If you look at who owns the seed in our country, it's global corporations, about 3 global corporations, including Monsanto. What that means for the price of seed, because people have to buy the seed every year, because this is terminator seed, it cannot be regrown, reused. And then I want to look at the issue of medicine, because if you take the TRIPS exemption, which enabled countries to access or to afford to access or to produce generic equivalents, the reality is that poor countries and middle-income countries haven't accessed the right. And to understand why they haven't accessed the rights, you need to look at the bilateral trade agreements. Because almost every single bilateral trade agreement with the United States, for example, writes out that right. That's been won by poor countries in the TRIPS exemption in terms of ensuring access to affordable generics rather than patents, which are owned by a very small number of companies. And to end, the issue of the general agreement in trade in services directly contradicts our constitution's defining of water, for example, or health or education as human rights. The general agreement in trade in services defines them as tradable commodities. Thank you very much.
Thanks, Prince. I think what we're going to do is we're going to allow the panelists to, starting with Moeti, to respond on any points that might have been raised. So each 2 minutes this time, and I think there were some fantastic things that came out of what Pregs was saying that perhaps should be teased out in the Q&A session afterwards. Dr. Themba, would you like to make a rejoinder point or an extra point there?
No, thank you very much. And I think, thank you for the comments that I think have been made by all the other panelists. I think the point that I'd just like to emphasize in relation to the issues around poverty and inequality, which I think have been raised by both Elroy and Pregs, is that really we need to look at health. All of society needs to look at health as an important input to development and also an important outcome of development. And so to address, the social determinants of health and the challenges that these cause means we need to be looking also at not just the global statistics of what's happening at country level, either in maternal health, child health, or any other indicator, but we have to disaggregate these to then find where the worst indicators are, localize those communities, and then direct resources towards them. I think that's the only way in which you'll be able to really deal with some of these factors. And as well as all the very good initiatives that government is doing in terms of the social grants and other social safety nets to address some of these vulnerabilities, means really hard and long decisions in restructuring the way investments are made in communities to address the disparities of the past. We have one of the most unequal societies, I think, globally, and it's going to take very long-term investment to do this. But I think we also need to make sure that the private sector, which is responsible for generation of a lot of wealth and use of a lot of human resources to generate that wealth, they need also to invest much more in the human capital that is part of producing that wealth, and see that their investment is actually protecting the human resource that actually looks after them. I think currently they aren't being asked to do as much, and they're major beneficiaries of all the investments that are being made. And I think it needs to be acknowledged that this is going to be a long-term issue. But I think in our kind of society and context, gender has been mentioned, and I think that is one of the most important things that needs to be addressed. And as Kofi Annan once put it, the greatest investment any society can make is to invest in the education of its women and its girls, and that's where you will get the best return on investment. But that's a long-term investment. Thank you.
Thank you very much. Elroy,
Certainly, it's heartening to see that there's concurrence by the speakers on a range of issues, and I'm looking around the crowd and people are nodding their heads. But there's a paralysis about getting to the cause of it, in my view. Within government departments, this erosion of the resources happens because of either policy, ideological, or personality differences. So people who are becoming increasingly hungry, people who lack nutrition in a deep rural area where I worked. Recently, Adelaide, which is in the Ndondo municipality, Eastern Cape, next to Fort Beaufort and Bedford. We found some very interesting phenomena. Government needs to agree on an intervention. The municipality said, yes, the population did decrease in Moba municipality. In relation to resources, therefore, there is an expectation that the budget will drop. Fortunately, a consultant who did the IDP, not that consultant should do IDPs, it should be a collective process, wrote that the drop in population density should not detract from the need to maintain or increase social assistance, because the widows, the grandmothers, and the children stay there. And the economically active young people are seeking places of work in conurbations, larger centers of economic activity. And migration patterns, urbanization streams are very important in terms of the calculation of equitable shares and conditional grants. SASSA sees that as enough to close down an office. The minister says, why did you close the office? Ordered the office to be reopened. So within one department you have ideological differences. Within a cluster, DTI, health, social development, there are huge differences in terms of solving problems. I think that what needs to happen is that maybe in future our governments needs to be incentivized when things get better, rather than just focus on problems. I think there needs to be civil society representativity on taking forward initiatives like the Brazilian Health Council, like the participatory budgeting mechanisms that is happening in many parts of the country, so that we can get better value for money for our limited resources. We have an economic growth rate of 0.6%. And yet our government allows that the largest growth rate in finance happens for unsecured credit granting. In 2012, the sector that grew in terms of the gross debtors book of 1.2 trillion rand, the smallest percentage of the total amount owed then was for unsecured lending, right? But it was growing at a pace of 49%. So more and more money was given to people at very high interest rates with no debt. Look what has happened. The Reserve Bank had to bail out Afribank. That has a huge impact because of our inequality on LSM 1 to 6, big time. And the laws protect people in LSM 10, maybe people like you and me, our money is insured. But the majority of people, because of the least amount of money being borrowed that is growing the fastest, are disproportionately affected. And that impacts on the quality of life, of health. If you go to Civitas building in Johannesburg, in Pretoria, 12 lifts. I worked there for 6 months. On any one good day, 7 are working. The rest of it are not. Baby Eco in Eastern Cape died. The Eastern Cape Health Crisis Action Coalition produced its death and dying in the Eastern Cape report, not on the basis only of crumbling infrastructure and staff problems in health. It was because of public works, because there wasn't an oxygen tank at the depot available to keep that baby alive. So it's a complex situation.
This is fantastic. I must say, this is the hardest job I've ever had, is keeping you guys to time, because I could listen to you all day, but unfortunately we've got to get to Bongiwe.
Thank you. I think it is actually a good thing that we all seem to have consensus around these issues. But I just want to touch on two very important things. The one is, if we define health as not just the absence of disease, and still continue to finance health through the Department of Health and through the health sector, we're defying our definition. We actually contradicting our definition. And if we go back to the case Savera spoke about, that is a case of something that's gone wrong in the environment, but unfortunately it lands within the health system. And it puts a strain on the resources within the health system. So until we start to think about health differently and plan around health issues differently and resource health issues differently, we'll be sitting with the same problem, where the health system is overburdened by a lot of things that could have been addressed outside the health system. The other thing I want to talk to is, perceived ineffectiveness of our engagement processes. I think a lot of people will tell you that, we have all these challenges in this community, and they will tell you about how many doors they've knocked on without any response. And I think that seems to be characteristic of South Africa. We don't address issues until people go onto the streets and protest and burn, and burn infrastructure and do all sorts of things. And I think that's a problem. Again, going back to the NDP has a huge emphasis on accountability, of government's accountability, local, provincial government's accountability to, the sphere of government above them. So local accountable to provincial, which is accountable to national. But we don't hear a lot about the downward accountability. Who are we not accountable to the people that we're supposed to be serving? And why do we not have mechanisms that can actually monitor, that form of accountability? And I think that's a very important thing as we try and advocate for this intersectoral, multisectoral approach, but also in trying to understand how our communities work and how we can improve the way they work and the way that they engaged in trying to address social determinants of health.
Thank you very much. And the Teacher's Pet Award will be coming in under 3 minutes. Okay, Pregs, another 2 minutes.
Thanks very much. I think that Bongiwe has made that point about the contradiction, the central contradiction in terms of how we think about and make budgets and the underlying macroeconomic policy choices that inform the budget, and then whose lives are valued and whose lives are not in our budget choices and in the macroeconomic policy choice that informs the budget. I think that somebody was saying to me this weekend that the way in which our economic, our country and the world actually operates, we value more care of money and machinery than care of human beings. And that's why you can actually cut the budgets of community healthcare workers, or that's why 95% of your water can be used by under 2%. And that's why those who were wealthy in 1994 have become wealthier today. Because if you actually want to understand that poverty, the inequality, you have to look not just at poverty, but at wealth, and how wealth is generated, and how we understand growth. There's a lot that is talked about growth, and yet we actually don't interrogate it sufficiently to understand who's growing and what's growing, and at whose expense. I remember sitting on a panel with, I think it might have been Danny Jordan at the time, and he said, that South Africa, that FIFA had made the biggest profit it made anywhere in the world in our country. So growth went up. But the question, and we know, is at whose cost? And we know a little bit more through the Competition Commission's case of the collusion of the construction industry, what some of that entailed. So the question of who pays, and the point that Elroy's article that he read out was really around the wealth going upwards rather than going down, and who's paying in terms of user fees. The fact that companies, that big mining companies, agribusiness pays less per kiloliter of water than households do, and that often poor households do, is indicative of these choices. The fact that tax in our country, that income tax, which is middle class and working class people, are paying more in terms of income tax today than in 1976, whereas industry tax has actually gone down. It was about, I'm not sure what the percentage was in 1976, but it was certainly over 25%. And today it's around, I think somebody said to me recently, it's about 2 to 3%. And if you look at the TRC, the TRC ended at the point where it looked at the gross human rights violations, but it left off a very important point, which was raised by Archbishop Tutu as the chair of the TRC, was the fact of the need to address the systemic human rights violations. And part of addressing the systemic human rights violations means that you actually have to look at the taxation. And they proposed a minimal tax. I think it was a 5% or less tax at the time, which was rejected by industry. So the question of, if you're going to be addressed this, you're going to have to look at government's priorities and who shapes and informs those priorities. Marikana, I was there recently as part of an invitation from the women of Marikana to come and see what their living conditions were and to do a site inspection and to listen to them do a speak out. And what we saw as we went into Marikana was that on the one side you had the huge electricity pylons supplying electricity to the mining company, the informal settlement where the workers come from, right next to the mining company, there was no electricity. And women told us that the water in many of the areas comes through only at night, so they have to go and collect the water at night. I mean, you connect the dots about what that means, about trying to address gender-based violence. Gender-based violence is not about vulnerability alone, about poor, shame, vulnerable women. It's about power and the decisions that we are making about power that reduce or destroy women's power. The General Agreement in Trade in Tariffs, the way in which it was implemented in our country, cost tens of thousands of women's jobs. What happens to those women and what happens to their children is that they become far more vulnerable. So we have to interrogate. If we're going to be looking at addressing the social determinants of health, we're going to have to address all of this. Thanks very much.
Thank you, Pregs. Okay, what we're going to do now is open the floor for some questions. We're going to just we've got a roving mic, or yeah, we've got a roving mic. Okay, so we should take the first question from the floor. If you can just, when you just identify yourself, who you are and where you're from, and to whom you're asking the question, perhaps as well, would be very useful.
My name is Matebo and I'm from Seoul City. Thanks to the organizers of the seminar, but I still think the room is small and the number of people who are hearing this is just too small for it to make impact. I wonder whether we have plans to take it out to a bigger audience. And because the topic, some of the things that came out there, some of it talks to, and came out very strongly, talks to fragmentation. And I hope that if we take it out, then we will also be trying to get the same people who are working in those spaces where there's fragmentations, to get them together, to hear this as a way of starting the conversation towards getting together.
Sorry, was that a statement or almost a media? Can any journalist here, please put your hands up and tell us how you're going to take this forward. I don't know, speaking on the Star's behalf, I suppose, like I'm fascinated, and I'll be speaking to you all later for maybe some op-eds and some, I couldn't even have written it as well as you were speaking it, so Elroy, particularly. Pregs, so I think, yes, but you're absolutely right, aren't you? I mean, that the fragmentation that we see is already seen in the fragmentation of societies. It's seen in the fragmentation of the attendance here today. And I think it is perhaps a sign of the bigger battle that we face, that unless you are faced with the issue, and I think it's what we've heard from our panelists today, unless you are faced with that, the awful reality of poverty and inequality, as Pregs was putting it, you don't understand. We don't understand. I don't understand before. And I think that's... So I just made a statement to answer your statement. So could someone please ask questions of the panel?
My name is Tanya and I'm from Themba Justice. It's really great to be part of this conversation, I think. I think for me, the question that comes is what's next? What do you see as a way to start the process of integrated programming, integrated solutions. I think even within our own organization, we're recognizing that working in silos, working on labor alone or health alone or all these other issues, it doesn't give as much of a positive outcome as an integrated approach. And I think that's the big buzzword right now in civil societies, working in an integrated fashion. But what do you see in terms of bridging the gap between civil society and government, and what can we do? You've diagnosed the problem, but what can we do now? And I think to the panel, I want to just put that question to you. What suggestions do you have, particularly to civil society? And then my second question is about teasing up the link between water and sanitation and gender. Just I want to hear more about that. You already gave an example of that.
I don't know if there's a single response from the panel, or does each panelist want to take a
Take a round of questions.
take a round of questions? Okay, so it's the first lot. Should we take another 2 questions and then we'll put to the panel?
Hi, I'm Tanya from Moeti. Pregs, I've got two questions for you. The first is quite straightforward. Are the findings for the research available? Okay. And the second one is you gave a very fascinating statistic. 95% of raw water used by under 2%. Could you please just tease that out and explain the implications? Because presumably it's not every corporation that's functioning in raw areas. So what's the other 98%? What does this mean specifically in terms of your research?
And one more question for this round.
Thank you. My name is Themba. I'm coming from the Democratic Nursing Organization of South Africa, DINOSA. I'm also happy to be here. And my question, I want to build it from what Tanya had asked. I think it was Tanya about what next. But for me, I've had 2 of the panelists mentioning NDP. And therefore the question is to what an extent, if it can, that the NDP can in a way address this fragmentation that we're talking about. Because to me it is a problem. I would assume that the Minister of Health, since he's a medical doctor, knows about the principles of primary care. All what we've been talking about, it's not something new. Anybody who's in health industry knows about that. So that is why I'm saying to what an extent maybe NDP can assist us, because also people what they say is a problem is that if you look at our political system, we elect people to government for a period of 5 years. So everybody is chasing that within these 5 years. To what an extent am I going to deliver? And you're not looking at whoever that you are supposed to collaborate with. It is about you and your department and what you want to achieve so that you can be re-elected. And therefore for me, it also creates a problem. And now that we have got the NDP, to what an extent will then all these departments will then in a way move from the same platform to say this is the document, this is what is going to guide us. And therefore whatever that I'm doing within these 5 years, it is in line with NDP, so that whoever that will come after me will also take it from where I left, because we all now looking towards one document which is NDP. So it's something that for me it always worries. Bongiwe, you have, I don't know whether it was a recommendation that we must use see whatever. I've just introduced, somebody talked about it. I wish you could elaborate on it. Why you are saying you are recommending it. Is it something that is going to assist? Because for me, the primary problem is this fragmentation. I haven't even touched the communities, because like I'm saying, I'm coming from the nursing sector, and if you hear everybody say nurses are the key drivers of primary health care, and to what an extent are we part and parcel and also involved in shaping the policy? We need another day. Thank you very much.
Thank you very much. From the panel side, I think there's obviously some questions directed to you, Bongiwe, Dr.
Themba.
Elroy, do you want to start with the first one?
Okay. Thank you. What can be done? A lot can be done. For me, as you were asking the question, Tanya, I immediately thought about citizen-based monitoring. Can I tell you why? The state and the power of political parties have wrestled our power away because of what I call, what the Good Governance Learning Network calls, invited spaces. Invited spaces are formal structures like ward committees, clinic committees, school governing bodies that unfortunately became politicized in most structures. Typically, if you want to participate in a ward committee, the law says it should be the ward councillor, the clinic committee, the clinic committee or the community health committee works along a similar structure. But you either with the in crowd or you with the out crowd. So good initiatives that start from a civic base is blocked. That is what we have found. And so in the work that we did in our Tambo and in Umgungundlovu district, we worked towards, and this is fun to speak, strengthening demand accountability. In other words, mobilizing communities to have them do this, have them hold the state accountable for their priorities. And this is where the tension comes in, because we also worked with alternative public accountability mechanisms. And I'll give you a classic example. The Eastern Cape Health Crisis Action Coalition campaign is a campaign the Black Sash belongs to. And we realized in what a luxurious situation we found ourselves in, Tanya. Because if you live in a poor rural community and you do work to alleviate poverty, guess what? Most of the time, the funding, the stipends comes from the state. And so when you see something wrong, you can't speak up. Fortunately, the Black Sash, being an old organization with various funding streams, even though we work with the Department of Health, and even though we couldn't wear this t-shirt, the RMCH t-shirt that has the Department of Health's logo on it, we took off this t-shirt, we used another funding stream, we went to show solidarity with the Eastern Cape Health Crisis Action Coalition campaign. And then a whole bunch of things happened. There was clever advocacy at play. A redacted report was written to protect the doctors who were the whistleblowers. The communities, in particular Treatment Action campaign, came in mass, and for the first time, the Health Professionals Council of South Africa marched with the Treatment Action campaign about the conditions of health in the area. The MEC of Health at the time called that coalition, and I quote him, "You bloody turncoats." And then we reported that finding to the Minister of Health. And the Minister of Health was shocked. He never knew about it. He said, "I will set up a commission of inquiry and you will get a report within 14 days. And that's exactly what happened. The MEC of Health in the Eastern Cape is no longer. There are partnerships that happen. When we engage in the Department of Health, it's a very different relationship between the DG and the Treatment Action Campaign and Section 27. So I think the first thing that needs to happen is that there needs to be a maturing and an appreciation of civil society work, things that civil society can do and that the state can't do. And citizen-based monitoring, which is led by the DPME, is one such tool. Because you see, the one thing that government departments don't like is to be compared against each other and to have the data, in particular policing. I'm part of a civic association, and the people gave up and they said the police don't do anything about it. And we said, no, set up a WhatsApp group, record everything. When things happen, report it to the police. Document it, write a report, and not only show it to the station commander, show it to somebody higher up. And that is a way in which we get our voices back. Not through only gated communities and keeping people we perceive as crooks out. We must take a real active interest in our work. And the thing that I don't like about my job is that Kevin said earlier on, I'm fascinated by what you said. I'm glad that you're fascinated by what you said, but I think our local communities should be fascinated about things that pertain to them. Who of you have been on the pmg.org.za website that has a rep locator, parliamentary monitoring group? It's free. It's a service where you click and say where you stay, and then you find out who your constituency leader is. Census 2001 can reduce the information to a ward level about your community. We don't know these things. We must become active citizens rather than passive users. Unfortunately, our former president, President Mbeki, popularized a Mr. Delivery concept of the state. And I think my intuition is to go counter to that. We must reclaim power, information, and active citizenry at the ground level. I think that's how we start.
Pregs, will you take the next one?
No.
I'll respond briefly to CBM, but I think my colleague Elroy has spoken about it already. So community-based monitoring is exactly the same thing as citizen-based monitoring. It is about reclaiming our rightful place as citizens and demanding that that government becomes accountable to us. I often like to think about government and the role that it plays as if you have a corporate, if you have a company, we as the citizens are the shareholders. And we've employed government in the various portfolios to be a CEO. Essentially, they are running the country on our behalf. And yet, as shareholders, we are quite happy to sit back whilst things go very wrong. It doesn't make sense at all. If you were in a company and you were a shareholder and you could see that your CEO was messing up, you don't want your shares to go down with the CEO. So you obviously want to stand up to it. And unfortunately, we have not inculcated this in ourselves, in our people, in South Africans. Often people will talk about how state money was abused without recognizing that it's actually our money. There's nothing like state money or government money. It's our money. Now, if your money was abused by anybody, you'd want to stand up and say, hell no. And that we don't see that. What we're actually seeing is, it's almost like the state, the government is over there and we are here. We're not taking ownership of government as the shareholders. As citizens, we are the shareholders. We own government. And we've just employed people to run it on our behalf in the different portfolios. So yes, my response is we actually need to rethink how we get citizens involved in decision making in a proactive manner. So we don't wait until things have gone wrong, but we participate in the planning processes to make sure that our voices are heard even beforehand. I also just want to respond to the question around the NDP. I think the NDP is a fantastic document in that it provides a roadmap. It charts a roadmap for South Africa over the next 30 to 50 years. And it's really a visionary document. It says, this is the diagnosis, this is what we think needs to be done, and this is where we want to go, and this is what we need in order for us to get there. But already within that NDP, there's a lot of contested issues. The next step beyond the vision is to then articulate an implementation plan. We haven't even gone to articulating an implementation plan because Labour's saying one thing and government's saying another, and civil society is already pulling in the opposite direction. So it's very difficult to say, how successful the NDP is going to be, because we already have these different constituencies wrestling for wrestling for power about what needs to be done and what needs to be prioritized. So I think, yes, we have a fantastic document. We absolutely need to take it to the next level. And our ability to take it to the next level in forming an implementation plan is going to be what determines whether we're successful or not.
Very much.
I think for me, just tackling the two questions very briefly and adding to what others have said around what next about integrated solutions and what is the role of the NDP? Can it help address this? And maybe very briefly, the voice of nurses in all of this. I think for me, about the integrated solutions, of course, I think we need to be under no illusion that this is going to come easily. I think people are very used to their territories, their way of working, and to change that is going to be extremely difficult. But I think if you look back to when the HIV era and national responses began, and I think you'd need to look not only within South Africa but beyond South Africa in terms of what happened on the continent. There was a time in which it was a very health-centered response in terms of what WHO at the time used to call the MTP, the medium-term plans and so forth. And later when it became very clear that one, the health sector really didn't have the authority to get the other sectors to do their role and do the actions that they needed. And then there were, the global community was struggling with how to then really get the multi-sectoral response that was needed. I don't think we've really achieved that in the way that we should, but I think it's put us in a very different place to where we would have been had this sector been left purely to the health sector to run. In most settings, right, we set up national AIDS commissions in president's offices and so forth, and hopefully that way you could then give better matching orders to the other sectors. But it really did change the response because countries recognize that, right, as a health-centered approach, we are not going to be able to do this. I think in the same way, the next development plan, as we look at the health sector, one, if we look at the National Development Plan to 2030, I think it really clearly articulates what the role of each sector is in contributing to developments in different sectors. Now, it is an excellent document. And if I look on where I've worked, most of my working life was in Botswana. But I think what really helped shape the development in the country was the 5 to 7 year development plans, where each sector's role was clear, and health, education, and all those other things were very clearly ingredients for development. And then the different sectors were then given their responsibilities. And one of the things you have to do is be clear also where you are allocating responsibilities. And sometimes the best way you can hold people accountable is to bring the decision making closer to the communities where things are happening. So whilst it may be easier sometimes to make sure that the national level is really leading the charge and getting everybody to follow what the national policy is, when it comes to its implementation, you really need local authorities and where people are much more accountable to the communities that they work with there to then be accountable for the delivery of those services. But I think the beauty of an excellent document like the National Development Plan is that if really it is taken, we move very quickly, as Bongiwe was saying, to articulating an implementation plan. And once that plan is in place, break that NDP into smaller periods over which there are very clear outcomes that you're trying to achieve. And each sector has its own particular role. And you have your medium term or whatever you want to call them reviews within those periods, so that at the end of the day you are then able to then say, right, exactly where are we rather, because 15 years is a very long time, and so it's got to be a living document. But I think it does present an opportunity if we use it in the right way, and I think it has to be a document that all sectors are very familiar with, and it needs to be clear that where does the accountability lie in terms of the communities that it's meant to serve and being answerable to them. And I think for me, this is one way in which this could be done, but you need a very clear monitoring process. On the question of the different, shall I say, disciplines in health and their contribution, I think Themba guy is right, yes, but we need to remember that public health or primary health care, whatever you want to call it, is very much a multidisciplinary a process. And clearly, I think maybe if the view is that there is one cadre or one or two cadres that are overly dominating the discourse and decisions and where they are made, then of course I think we will not be successful in the long term. And in countries where the resources are much fewer than those that we have, I think these voices of the other cadres and disciplines are much stronger, because it's clear that their involvement in delivering what's necessary is much greater. And I think that's what we need to continually strive towards. I think the policy statements are quite clear. We've moved away from a hospital-based health service, and therefore I think it then clearly means unless you have all these other cadres right down to the community involved, then the whole principle on which we are trying to get this evolution and change to happen will not happen. But I think we probably have better tools to address these things than we did in the past. And I think it's up to us then to make sure that we do hold people accountable and that what's stated in our policies actually gets done.
Thank you very much. Pregs?
Thanks very much. I think in relation to what's next, sorry, the question from Tanya in relation to, I think there's been a number of suggestions that the panel has already raised, which I'd like to support, in terms of particularly civil society. I think the question of the media and Soul City itself, the question of changing the stereotypes and the stigma, because and then being able to say, well, who's accountable? And part of, I think that one of the biggest stigmas is around poverty. And if you actually are able to, as a government, as a country, to say that the problem with the water is the dripping tap in a poor community, and yet the stats show that those who are using most of South Africa's water is industry, and those who are wasting most of South Africa's water is industry. Those who are polluting most of South Africa's water is industry. And those who are stealing most of South Africa's water is industry. Why is that not shifting the paradigm in our country, in government and in civil society? Why aren't we asking these questions about accountability? And I think it's easy to stigmatize people who are poor. They're wasting the water, they're stealing the electricity. And these stats that I'm talking about, water, are actually often applicable to electricity usage as well. And I think part of that stems from the way in which we see macroeconomic policy. So when we talk about the NDP, my question would be, does the NDP sufficiently address the criticisms that were raised about GEAR, which was the macroeconomic policy choice that has roundly been rejected by government in many of its statements? But the question is, in terms of the hard choices that were being represented in that a key part of it was to attract foreign direct investment, and therefore you will give highly subsidized water, electricity, etc., that becomes commodities, and therefore you don't question how much of this water is being used and how little is being paid for that water. Or when that water is polluted, you don't have many cases being brought against those who are causing most of that pollution, and therefore most of the illness that flows out of that pollution. In the Commission, we deal with cases of arsenic poisoning in the water, acid mine drainage of water, etc. And we're dealing then at the health consequence level rather than the cause level. So I think the issue of the media and Soul City is, how do you begin interrogating this? Because part of the interrogation addresses the question of who holds power, which I think my fellow panelists have raised, is who holds power. And therefore, why is it that we cannot begin to interrogate that? Recently, one of the editors, a newspaper editor, raised a response to a critique around why is it that her newspaper and other newspapers are not dealing sufficiently with business corruption and etc. And she said, well, it's dealt with in the business pages. And actually, that's not a good answer. It's actually about how do you deal with it in everything, and why is it not a huge hitting the front pages of the newspaper that the Competition Commission found this collusion, and yet the payment was a small fraction of the huge profits. And so shifting the mindset to beginning to interrogate these questions, I think, would actually move us forward around whether we're looking at the NDP in terms of, are we sufficiently taking on board those critiques that have been raised of the NDP, and not seeing it as simply, well, it's the unions opposing this, but is there some validity to some of the critiques? does it sufficiently? I'd heard Adam Habib, for example, raising the question of the inequality, and that it's not sufficiently fleshed out, that the NDP doesn't sufficiently flesh out addressing the inequality. Yes, it's addressing poverty, but you're not going to sufficiently address poverty and inequality, because they go hand in hand, if you're not going to address the inequality and flesh it out thoroughly. So I think the way in which we have debates in our country, the way in which civil society engages those debates is essential. And I mean, the health department has raised a very important issue around the patents, around the need to reform patent legislation in our country, the intellectual property legislation. And it's one that civil society needs to understand. Society needs to understand why this is critical to medicine, to affordable medicine, and what's the direct impact and line between the two, and why it's absolutely essential that everybody be talking about this and making sure that this happens. That intellectual property, the intellectual property regime globally and in our country doesn't enable our country, or any country in the world that is poor, that is dealing with massive health challenges, to address affordable medicine for people who are poor. So that would be a critical question for me. The issue of water and sanitation and gender, I mean, I think the approach of the Commission was really around the reality that if you look at the apartheid spatial geography, it's also it's a patriarchal, it replicates the patriarchal reality that those who were worst impacted during the apartheid era were black, working class and poor women in former apartheid homelands, townships and informal settlement. By poverty, by HIV and AIDS, etc., etc. So the issue is that how does that inform policy? Do policymakers actually understand what that would mean then? Would you continue, where would you build an antenatal clinic? Would it be on top of a hill? Or where would you, and I'm taking a facetious example, which actually I've seen in another country, where the most important thing was the name of the donor that was on the clinic. But yeah, I think that it then begins to inform how we make policy choices. The budget is premised on an average citizen, a citizen X, but you begin to interrogate that and you see this, well, the citizen X is highly gendered. And it's not just gendered, but it's a whole range of factors that constitute that citizen X. So the way in which then that begins to impact on policy at every level, whether it's in relation to water and sanitation or anything else, but specifically in relation to water and sanitation, obviously it's questions of hours of walking to and from, and issues of safety, but also issues of gendered roles and responsibilities, which we must change, but which haven't for the most part. And so the question of responsibility for cooking, cleaning, caring is sitting with women, and they're the obvious impacts of if you don't have water and if you don't have sanitation, or if the sanitation's inadequate, what happens in terms of caring for children who get sick on your time. And the assumption of policymakers is that women's time is infinitely elastic, and you can, and you know the consequences of that. The findings of the water and sanitation report, yes, it's on our website, and it's available and can be used. The stats that I talked about, 95% of rural water is used by under 2% of the population. That comes from a senior researcher at the National Water Research Commission, who said to me that this is the stats at the National Water and Sanitation Summit. Just before that, she'd given it to me. And it was, it's largely agribusiness. That 2% of the population is largely big white farmers who are still using most of the water in rural areas. I think those were the key questions. I'm not sure if I've missed. I think I've covered it. Thank you.
Ladies and gentlemen, we're almost up on time, but should we try and take 2 more questions and see how that goes? Because we're getting very comprehensive.
Can I just sort of raise one thing?
Certainly.
Sorry, just in terms of the Commission's about holding government accountable. One of the things that we found with the hearings on water and sanitation was the importance of holding government accountable to communities directly. So the one thing was that we asked government through the presidency's DPME to give the Commission a report on what was happening in every single municipality in terms of access to sanitation and water, which they gave to us. And we asked them to give us a plan on how they would address that. And a key question would be, what is the plan? Because if the proactive plan, and they've made a whole lot of commitments, that plan is part of our report. You can see it in the report. But we've quoted significantly, but we've also got links to that plan. It would be important for civil society to hold them accountable to that plan, to say, well, what's happened so far, and how have you actually given effect to this? But also what we did was we asked DPME to come to every single one of the hearings so that they could listen to what communities were saying and respond directly to them. And so communities had level of accountability, not just to just local government and provincial government, but also to national government, to ensure that kind of accountability. And I suppose with what we've also done is we've worked with the DPME to ensure that in their performance monitoring system, that it now includes, that the DGs have to sign off on in terms of their contractual obligations, that it includes the ensuring compliance with access to information. And not just as a technical compliance, but in terms of the Constitution's call for open, responsive government.
Thank you very much. Okay, 2 more questions. Maria, please.
Hi, my name is Yusuf Saluti. I'm with the National Council Against Smoking. One is more comment than a question, and the second is a question. The first is 2 of our panelists spoke about allocation of budgets. Now I want to look at this issue of budgets. If you look at the population of South Africa, you'll find that the majority of people are healthy. Okay, so it's a pyramid. The majority at the bottom are healthy. Above them comes another layer of people who are healthy but whose health is at risk because there are various risk factors operating. Above them comes the third group who apparently are happy but have disease but are not seeking treatment for the disease. And then the final group are people who are ill and are actively seeking treatment for their disease. That's the population. Now if you compare that to spending, health spending, you'll find that 99% of our budget goes on the few people at the top who are ill and actively seeking treatment. And very little money goes on treating, on the larger part of our population who are healthy. Now again, if you look at South Africa, if you look at South Africa over the last 20 years, all the risk factors for health, behavioral risk factors, are getting worse. People are becoming more obese, alcohol use is going up, people are eating more poorly, exercise levels are going down. The only one where we have good news is smoking. Tobacco use has gone down in South Africa. And that's not an accident. That's a result of government policy. Now what we are suggesting, a group of people, including SOCITY, the National Council Against Smoking, the National Research Council, is that we need to follow the example of Thailand. In Thailand, it's gone exactly the other way out. Violence has gone down, road traffic accidents have gone down, smoking has gone down, all the risk factors have gone down. Why is that? Thailand is similar to South Africa. The reason is it's allocated more money to prevention of disease rather than treating it. And it's got what is called a Health Promotions Foundation, whose particular task is to supplement the National Health Insurance Scheme by promoting health. So that is just a comment, if you would allow it, and I would like if you have any comments on that. The other thing I heard the word nanny state used. And for me that's a red flag. You know, again, it's a question of who shapes policy. What is a nanny state? Is a nanny state protecting its citizens from harm caused by other people, or is a nanny state's duty to allow people to harm our citizens? And I'd like to get your views on this so-called nanny state.
And the final question?
Thank you very much for the input. It was really, really challenging. Just in terms of the what next question, response to what next, even though it's a very small response, in terms of trying to get increased accountability from government through our campaign at Soul City and with our partners here today, we want to use the Human Rights Day at the end of, in the beginning of December, to do a report card on the 6 government departments that I identified earlier on, which just because I forgot some, was Department of Basic Education, Health, Water, Electricity, Gender and Transport, that we want to take some of the research that's been discussed here today, put it into a report card, and then again have a public debate and panel, and hopefully get government to be present at that panel, and to use that to continue the conversation about accountability and also about how government services can be provided differently. But alongside that, I also want to challenge my colleagues, our colleagues in the media, about the stigmatization of poverty, and also about the way in which reporting happens when there is a lack of service delivery. Because I think a lot of the questions that have been raised here and a lot of the links that have been made here are missing in the coverage that we see on the reporting of these kinds of events. We tend to see service delivery or health issues reported in a very insular kind of way. So one event is not related to another. We tend also not to see the interconnectedness of service delivery issues raised, and we tend also not to hear government being asked the questions of accountability, and rather that the reporting begins and ends on the incident itself. And I would really like to challenge our colleagues here to use the resources in the room today when reporting on these issues.
Thank you very much to you both. Is the panel ready to take who's going to go first? All right.
I think I used the term nanny state. And I was quoting what a government department asked us. It was in the context of whether people who get grants, whether it's a child support grant, a state old age pension, disability grant, should be dictated to how they use the grant. Now, a little bit of context. When the government used a significant percentage, given high unemployment, inequality in South Africa, to calculate the amount of money for these grants, and it's a substantial amount. It's about 120 billion rand in this financial year. It was within the South African context. But work has shown that the grants were provided to communities and individuals living in extreme poverty, and research has shown, HSRC, government and ours, that those funds are used for mainly food, transportation, rent, funeral insurance, clothing and school fees. Now you have another government department who says, who are you to decide what the interest rate should be for that person to use a grant for a loan? Our view as an organization is that primarily the money was meant for what I've highlighted. The minister and the law says that no grant may be ceded, transferred or encumbered in any way for a loan. If you borrow money for consumption, to buy food from month to month, you're in trouble. your household indebtedness will increase. But yet, this is the very loans offered by either machinistas outside or corporate structures now to borrow money. So that was the context in which some government department and officials say, no, let people decide what they use it for. But the consequence of that is increased indebtedness. I think that in as much as the law also says that the minister may criminally charge somebody who uses grants for collateral and remove the grant, the question that Pregs raised about corporate accountability is, why don't you criminalize the lender who knows more about that? It's just the fairness. It's the structured way in which the poor are blamed for actions that sometimes they couldn't resist the temptation to feed their family for. And this is over and above illegal and unlawful issues. Another thing I need to share with you is that the citizen-based monitoring, the CBM, that is now formally adopted as a framework by the presidency, which was approved by cabinet, arose because of several civil society initiatives, including some work done by the Black Sash and Social Change Assistance Trust, funded by the EU and a few other funders. That was a project of the Black Sash. So DPME will say they were inspired by Community Monitoring and Advocacy Project CMAP. Now, the interesting thing is about CMAP is that government has adopted that as a formal policy, but it tends to get watered down if officials use it to monitor performance and reduce it to a scorecard, a number, without giving the human face and the human rights aspects of this. So ourselves, Black Sash, is working in a separate project called Making All Voices Count, where we're monitoring 20 sites and we're using tablets and training communities how to monitor their own services, including health. And this is the other complication. SASSA, who is in the papers for all the wrong reasons right now, have given us formal permission to monitor their sites. If you do that with health, it's a huge challenge. Facilities don't know what their budgets are. Local structures don't know what their budgets are. Sub-districts. Districts is where the money is divided. Then you have provinces who know what their budgets are. And then you have a very highly bureaucratized National Department of Health that will decide in different directorates how money is spent. And the work of Health Systems Trust, in particular the District Health Barometer, has come alongside the National Department of Health to provide very, very valuable statistics about how those 46 government departments work. Why I'm saying this is interventions and accountability by civil society structures through monitoring and other initiatives has a different nuance in each kind of government department you monitor. But we must share that information with government and demand a response. Because if we leave that to so-called experts and have a one-size-fits-all model imposed, it's not going to work. I mean, I learned the hard way that vast in Northern Cape is very different to vast in Eastern Cape. You can get from Kimberley to the R with a good car in a good enough time, but you can't get 15 Ks to Upper Tutuza Clinic in an ordinary car. You've got to use a 4x4. I learned the hard way. So the point I'm trying to make is, in as cosmopolitan and different as we are as South Africans, health is challenged by all these complications and these unique challenges. If you go to a place like near Coffee Bay, the clinic that Dr. Ben Gaunt manages, Zitulile District Hospital, there's a practice where children are born with a birthmark. Then there's a cutting here, which causes meningitis and causes children to die. So we have to work with traditional healers in certain areas. If a mom has given birth in Umgungundlovu, a male cannot enter the household that is not part of the family. If you go to the Western Cape, you've got, I was born in an area in the Cape Peninsula where I could choose 3 academic universities and 3 tertiary institutions. The persistence of apartheid spatial geography on the ability to access healthcare in our country is very different. The city of Cape Town never answered the Black Sash question. It boasts that it has amongst the best health services ever, but it's got 8 health sub-districts. To its shame, the Western District, which is the other side, Clifton, where Michael Jackson had a house, that infant mortality rates was way below the universal minimum of 18 deaths per 1,000 live births. Theirs was like 11. But for the last 6 to 10 years, Khayelitsha and Mitchell's Plain was 36, 48, 45, 52. Both so-called colored communities and newer migrated families living in Khayelitsha, if you know the history of Western Cape, have the same, if not the worst burden of disease, and that hasn't changed. And that's why it's important also to look at issues of inequality in health and the decisions that needs to be made in the division of revenue. Last point, the Financial and Fiscal Commission is a statutory body that is underestimated in terms of their recommendations. They have said that the social wage in times of hardship should never be decreased. In fact, it should stay the same or increase. And those considerations were never taken into account. So when money is divided based on whatever factors the National Treasury calculates, the rights of a rural person or a person staying in a peri-urban area, those Section 27 rights, are as important and as valid as somebody in an urban area. But the cost of rendering the service to that area is clearly more expensive because there needs to be more layouts. How do we as citizens and media hold government accountable? Because if we don't, then unfortunately our rural areas, the citizens living in our rural areas will continue to be drawers of water and hewers of wood, because the indigency percentage in rural municipalities is 83, 85, 90% plus. There's no revenue base. So the division of revenue and the allocation of resources must be looked at very seriously.
I was going to try and touch on the Health Promotion Foundation one, but more as by way of comment. So I don't know if my colleagues want to respond to any of the questions, because I think in the interest of time that may be more important than a comment.
Thank you. I just wanted to touch briefly on, I think the important point that Dr. Saluji raised about, the role of the state in promoting health, and I guess then the challenges around how the state exercises this role and people's interpretation of that perhaps as being an anti-state and so forth. I think it's a very important question, because what you have here is the question really of government and society, taking responsibility to protect people's health at an individual and a population level. And if you look at the NDP, I think one of the key principles is that, it is to provide affordable access to quality health care while promoting health and well-being. And often when the issue of action that is necessary to promote population health is taken, such as in smoking, and I think the global framework against tobacco control, I think, was a very important achievement, but it was a lot of work to get there, and I think the potential public health impact of that is immense. But at the end of the day, what this really boils down to generally is that it's the action that government and society is having to take to protect population health, really against the interests of big business, industry, where it is more the financial concerns that are most important. And of course, the challenge is that down the road, these are not the entities that then meet the costs for that ill health, which are then borne by society and so forth. And so they've got no real incentive to try and make sure that they address those things. So I think government then does have a role. And quite often, communities do need help, they do need education, because quite often it's a natural human tendency not to worry about things that we see as 20, 30 years down the line, because that's not the reality that we're dealing with, today. But if you look at what's been done and achieved in smoking, and look at long-haul flights, for instance. I mean, people used to believe that they'd never survive those flights if they were not able to smoke, but they are able to take their 15-hour flights to the US and so forth. Restaurants were complaining at one time that they'd be closed out of business if people were not even able to smoke in those areas. That just hasn't happened. But the benefits to human health as a result, I think, are much, much greater, and even the environments in which those businesses have to work. So I think, government should not, and society shouldn't flinch at this responsibility. And I think the good data that comes out of each effort needs to be shared, needs to be distilled in different ways so that people can then be able to access that information. Okay, as Elroy mentioned, the Health Systems Trust produces an annual document, the District Health Barometer. All right, that's a very technical document which probably the ordinary man in the street will not see and will not read. But it does distill data on performance at district level and can disaggregate it from what you would get at provincial and other levels. And then you can then hone in on where some of the problems are occurring. And so if this information can be used to judge performance or monitor performance, and then inform action going forward, which is, I think, and planning, which is the important thing, then hopefully that same data will get to those communities so that they know the difference between their communities, their societies, and others, and what needs to be done for those investments to make a difference. And if, nanny states do good things, then I guess that may not be such a bad name, and we should be focused more on the outcomes of what's needed to be done. So I think from a public health perspective, that's not something that would worry me so long as we're using that term in the right context. But thank you for raising a very important issue.
Thank you, Chris.
I suppose just quickly to say how gendered terms can become in relation to denigrating the care work that's essential to society. And I think the point that I'd made about how much more we value the care of money or machinery rather than the care by human beings of human beings. And that's reflected in the use of the word nanny state. It's an ideological term which is strongly loaded and was really used to discredit the social welfare systems across the world, and it has seen an undermining it's linked to the undermining of those rights. So I think that it reinforces how important the work of Soul City is in terms of being able to communicate and to challenge the ideas and the thinking that underpins that. I think that the issue that you've raised around a Health Promotions Foundation is critical because I think that there is a good example within our country around tobacco and smoking, and it is going to mean that the question of government's regulation of industries which are damaging to people's health and how those industries operate, whether that's in relation to food, and the example I'd given about Monsanto's ownership of seed is also about the impact of GM food on health. South Africa, I think, is the only country or one of the few countries in the world which has allowed its staple food to be genetically modified. So the issue of a health promotions industry would obviously look at all of that around both the promotion of, I saw an interesting thing in the media around sugar, and from somebody who works for, I think it was Hewlett's Sugar or Tonga Sugar, I can't remember, but she'd written an article to the paper in which she misquoted certain studies. The World Health Organization says that sugar's not bad, really. And sugar's actually healthy for us. So I think that there's a lot of resources and money which people who are more interested in the promotion of their profits rather than the promotion of health is something that's going to have to be, and I'm sure you more than anyone else knows the impact of that. But I think there does need to be an engagement with how do you communicate, how does the media, how does Soul City communicate and challenge those ideas? Because I think that a big problem is the issue of, there seems to be a fear of the regulation of industry. And we've seen that in relation to a whole number of areas, but obviously that would be in terms of health as well. So I think that when you do the report card, I think when Soul City does the report card, I'd be really interested in how government is regulating industry, not just in terms of contracts, meeting human rights standards and norms, but also the regulation in terms of whether it's the pollution of water or whatever it is. How's government actually doing that regulation? Because you've got mining licenses being issued left, right, and centre without really the social and labour plans and the environmental impacts that are supposed to be essential to that process. And I suppose to come back to the question of, I'd just like to add on to Elroy's point around who's criminalised. And I think that issue of who is criminalised in relation to the stigma, people who are poor, the stigma around people who are poor, and it's raced and it's classed and it's gendered, and a whole range of other factors that intersect with that, and we see that not just in our country but across the world. So we're seeing that at the moment in the United States, and we see that in the prison complex, the industrial prison complex. So I think we there's an opportunity here to begin to think about health and the social wage that Elroy's raised. That you can't not look at what are those macroeconomic policy choices that increase unemployment or precarious employment, and the gendered consequences of that, because the drive to the lowest wages, the lowest working conditions that companies do across the world, not just in our country, is highly gendered, because those who are getting those precarious jobs to produce our cell phones and our computers and everything else are generally women working without the protection of the labor laws that in our country women workers fought for. Thanks.
Thank you very, very much. Dr. Paulus, very much to give a vote of thanks.
It's difficult to end a conversation that's been so fascinating and that's been so rich. So I really have to thank our panelists for their excellent inputs and their preparation, because that was very clear, with the kind of issues that were raised. I want to thank you as well, Kevin, for excellent chairing, and all of you for being here. When we started this campaign, we thought long and hard about what would be a good advocacy issue, because we know that the Department of Health is very responsive in many areas. We have a minister that we all have a lot of admiration for, but at the same time, when we look at the health outcomes, in spite of those policies, in spite of that excellent minister, we still find we still find terrible health outcomes, given the amount of money that is spent, and the quality of life that we're living, that our population is experiencing. And also given that it was 20 years since our democracy, that is a tremendous marker. And so it becomes necessary for us as an individual organization, but also as civil society and the media, to challenge our government more on not just the health outcomes, but on all of these other areas which we've talked about today. I think this morning's discussion raised challenges for all of us, actually, for civil society, for us to be able to say, how are we taking this information forward for government in terms of their service delivery, the kinds of policies that they've put out there, and most importantly, where they're allocating their budgets. I think for the media as well, there are questions about the way in which reporting happens, and for all of us as citizens, what are we going to do and how are we going to do it collectively, so that we're not just talking about things, but we're actually acting on them as well. So thank you everyone for being here.
There is